Okay.
We don't have MRI this case.
Yeah, it's okay. Adductor minimus is
They do
not adductor.
they do CT
Gluteus
also,
minimus
right?
is affected.
In Japan, they do more CT.
Gluteus maximus is very well preserved.
Yeah.
Cơ mông lớn của bệnh nhân này thì rất là tốt. Cái này là CT cơ. Tell me when you want to stop.
Okay, it looks normal. Go down.
Is the hamstring normal?
Hamstring normal. Adductor magnus may be affected. Can you go down farther? No, it's okay. Maybe this one, adductor longus, is affected here on the right.
The magnus?
Adductor longus. Adductor magnus is also affected on the right side.
Cơ kép dài và cơ kép lớn thì ảnh hưởng cơ phải.
Yeah, TA is gone on the left.
Cơ chạy trước nó biến mất rồi phía bên trái.
For me, the pattern is completely different from GNE myopathy at least. Can you go up to the thigh?
Cái này thì nó khác với một cái bệnh cơ GNE. Ông muốn coi lại cái mũi.
Yes, yeah, maybe you can stop here. So one of the features is very much asymmetric involvement, right?
Rất là bất đối xứng.
Yes. And I think for both sides, I think adductor longus muscle is affected.
Cơ kép dài bị ảnh hưởng.
Yes. And can
Can you tell us about GNE?
No.
GNE, what will it look like?
Well, in GNE myopathy, adductor magnus is affected and also backside hamstrings are affected. Can you go down further?
Nếu mà GNE myopathy thì cơ kép
So
lớn
here,
và cơ
semitendinosus is a little bit affected, but not much. But here, can you go down further?
Down.
Yeah, probably this is semitendinosus and also adductor magnus is affected. So this may be really, if this is really in early stage of GNE myopathy, maybe okay. But tibialis anterior is already all gone, right? I think this is not compatible.
Nếu mà giai đoạn sớm của GNE thì cái này chấp nhận được, nhưng mà không phải giai đoạn sớm đó, tại vì chúng ta thấy là cơ chạy trước nó biến mất hết luôn rồi.
Yeah. Can you go up a little bit? Yeah, stop. Go down a little bit. This is not really tibialis anterior, right? This is tibialis anterior, but can you go up a little bit? Can you go up?
Go up.
Yeah, stop. Yeah, TA is affected, but I forgot this one, tibialis posterior or something else is also affected here. So I think the pattern is different. Yeah, and really at the proximal portion.
So remember you were saying about the problems with MRC testing, right? I think
right.
the other problem that we have as clinicians is that, you know, when your foot is very weak, your hip can look weaker than it is.
Right.
So we often overrate the weakness of the hips.
Yeah, exactly.
While here you can see the muscle looks quite, gluteus is quite normal, right? So that's why MRI or CT is better, because in clinical exam,
Yeah.
when the foot is very weak,
So muscle
often
imaging is very
we
powerful actually.
overrate proximal weakness, you know.
Khi mà cái phần ngọn chi, phần nhãn chân nó quá yếu ấy, thì cái việc mình đánh giá cơ gốc chi đôi khi nó hơi bị quá mức, do cái hiện tượng yếu nó bị bù trừ, nó bị ảnh hưởng. Do đó là cái CT scan thì tốt hơn là có cái CT để đánh giá cái cơ.
Okay, sorry, I don't have conclusion, but all I can say is this looks different from GNE myopathy.
You will show me to make that, because I don't remember all the
Yeah.
myopathy. So
Good. Sure.
Yeah, of course you can show it, but the problem with Alan Pestrom's site is he showed only one slice
Oh,
and only one case. So, there are actually variations, right? So, well, I think we need, so in my lecture, in my talk, I showed the almost like heat map, which muscle is more significantly
I see.
affected while other muscles are relatively, less affected. I think we need this type of data. And of course, representative picture as well, but he just showed a representative picture. So I think of course this is useful, but I think we need more like
Heat maps.
scientific data.
heat maps, huh?
Yeah. You
wanna
can show
show-
GNE, for example.
Show the rest.
Đây là cái trang web thầy Uma có giới thiệu với mình khoảng 5-6 năm trước gì đó. Thực ra là do bệnh cơ mình cũng không nhớ hết được các cái đặc điểm lâm sàng của nó, cho nên là mình coi website này như là một cái la bàn ấy. Thì nếu mà mình có một cái trường hợp bệnh cơ thì mình cứ vô đây mình sẽ thấy là có một cái nhóm là bệnh cơ về ngọn chi. Như ca này mình khám xong mình nghĩ là bệnh cơ ngọn chi thì mình sẽ đi tiếp ở đây thì nó sẽ phân loại nhiều cái nhóm nhỏ hơn thì mình sẽ đối chiếu với cái lâm sàng của mình. I'm just talking about when
Yeah, sure.
when I make sure it's visible when
Correct.
we go directly to because I have to check.
Yes.
How about the MRI or the biopsy?
Then MRI, you want to show them where to find it? Radiology, right? If you go back to the first page, then under lab features, there is
Cái này là cái website
below.
của Đại học Washington. Các chị lên
Yes,
Google cứ đánh là neuromuscular
Yeah.
rồi Washington University.
is there a lab?
Nó sẽ kết nối trực tiếp tới cái trang này.
Radiology, no?
They also have MRI.
Yeah. Show them where to find it. So, then
I
the
think
MRI.
they have
MRI.
CT or MRI, typical MRI
Then-
presentation.
So MRI patterns of.
Yeah.
Okay, you want to show. So GNE, for example.
Yeah, GNE, for example.
Let's go to GNE. Where's GNE? Can you see?
Yeah, this one.
Okay.
I think you have to scroll up.
Okay.
Yeah, this one, right? Of course, this is useful. This is a typical presentation. But in early stages, of course, some muscles are still there in hamstrings. So I think of course, this is useful, but you should know that this is only one typical case or
Sure.
two typical cases, right? So there are variations.
How about UDD or tibial?
And that is only TA is affected in these cases. And also the patients are only in Finland or somewhere.
Finland.
Yeah, if you find any case tibial muscular dystrophy in Vietnam, this will be very surprising. Of course, if you may have it, but and the pattern is very different. And thigh muscle is not affected. Yes.
We go to the muscle.
Yeah, okay. So which muscle was biopsied?
Yeah.
So can you tell us about biopsying these patients? What
Yeah.
muscle should they biopsy?
Actually difficult
Yeah.
to tell. Yes. But maybe TA is okay. But so if you look at the muscle CT, not lower part of TA is of course affected, but only in the upper part. Lower part, okay, middle part is almost normal. So if you do biopsy from here, it may look normal. So it's very tricky. Yeah. So I will show you.
Cái này mình sinh thiết cơ mà nó bị yếu luôn ở cơ chạy trước á, nhưng mà do cái cơ chạy trước nó rất là dài cho nên việc mình sinh thiết chiếu phần nào của cơ chạy trước nó cũng rất là quan trọng. Do đó là dựa trên cái hệ thống học mình sẽ chọn cái cơ, tuy nhiên là cơ chạy trước thì cũng hơi khó, tại vì cái vùng này nó có cái thần kinh chạy thần kinh cái mát đi vòng vòng ở đó mình cũng.
So actually, this is a relatively large specimen, but at first sight, it looks almost normal everywhere, almost everywhere. Yeah, so, but I really looked for abnormality very hard. Then I found only in this area, I saw some atrophic fibers. Like this, you can see small angular fibers here, maybe this one, and
Nhưng tổng thể
Yeah,
cái ca này dường như là bình thường thì chỉ một vài điểm thì thấy là
yeah,
có cái
this one, and this one. as well. So they are not really clustered, but somehow, suggesting there are atrophic fibers, but not in this specimen. This is only really at the edge, and I found only few atrophic fibers. So probably, yes, you are right. You should biopsy tibialis anterior, but maybe a little bit higher places. Otherwise, it's really, there is always sampling bias, sampling error in muscle biopsy. So it really depends on which part of muscle you take. I mean, unfortunately, this is not really informative. This can be, of course, neurogenic, early neurogenic, but this can be also kind of myopathy. So
Actually, I would have done the same thing as him because I would be worried about end stage
right.
proximally.
Yeah, but a little bit higher at least. Yeah, this is clearly
Normal.
too mild.
Too mild.
Right. Yeah, it's very difficult. Yeah, you are
Cái ca
right.
này thì nên sinh thiết cao hơn, nhưng mà thầy Uma nói lại thầy cũng sợ cái chuyện là mình sinh thiết vô trúng cái cơn mà bệnh nó quá nặng.
So this is the only abnormality I found actually.
Those are artifacts, right?
The holes
Yeah.
are artifacts,
Yeah.
yes. But in other area, I don't see any abnormality actually. Well, of course, I sometimes find this type of fibers with internal like.
Are those what do you call it?
Group atrophy?
No. In myofibrillar myopathy, you get this. What is that called? The focal. I thought that I saw some focal staining.
Like a protein.
Cytoplasmic
aggregate.
bodies.
No,
No. Huh?
I checked modified Gomery trichrome, but I didn't see anything.
Okay.
And unfortunately, in this laboratory, you don't have myosin ATPase, so you can't really differentiate fiber type. But it looks like many fibers are type 1. Yeah, but tibialis anterior muscle is known to be type 1 fiber predominant, so I can't tell whether this is a neurogenic or from the beginning.
Nếu mà có ATPA thì sẽ phân biệt được myogenic hay là neurogenic. Cái này chắc nhà chị Thư thôi chứ mình không có mua.
Yeah, so from time to time, you see this type of small angular fiber, atrophic fibers. But they are not really clustered. So I don't think we can tell this is neurogenic, but can be neurogenic. Here as well, you can see small angular fiber. Maybe, well, this is maybe minimal group atrophy, but I don't think this is definitive.
If it's not myopathy, in this case it's neurogenic.
Yeah, this can be neurogenic, can be myopathic. You can't tell from this one. It's inconclusive.
Because the distal SMAs or the CMT, pure motor CMT, if you go to the website, there are so many genes for those.
Yeah,
so
but
this could be one of those.
yeah, but distal SMA usually adductor longus is preserved.
Adductor longus.
Longus is in this case adductor longus was affected, and adductor longus can even be hypertrophic. Yes, so from muscle imaging data, I think distal SMA is unlikely. Yeah.
But then there are so many types, isn't it?
Yeah. Well, at least 4 types, I think, from the gene.
Professor Uma, do you think myopathic change on EMG is objective?
On EMG,
Yeah.
I find difficult. So if the pathology is also difficult to show.
Yeah, this is
because if you
tricky.
think about it, if you EMG this muscle, should have been quite normal, right? Your EMG should have been normal because it looks quite normal here. But you found myopathic changes, so not sure.
Cái đánh giá mà bệnh cơ trên điện cơ thì như thầy Uma là bậc thầy về điện sinh lý,
P62.
nó khó, nó không dễ.
P62.
Riêng mình thì thấy nó rất là chủ quan, tại vì mình cũng không có một tiêu chuẩn nào để gọi là kết thật sớm. Đa pha thì rất là nhiều nguyên nhân, kể cả bệnh thần kinh giai đoạn sớm, rồi nó cũng có tăng cương như là đa pha.
MXA. No,
I just say that
this is not
early
double
recruitment
muscle.
is objective
I
to
need
me.
P62
And
for
basically
protein
we
aggregate.
have two neurologists and we have agreement it's in my
I agree. No, I'm not saying it's your fault. It's just the EMG it's the weakness of EMG I find is in distal cases. I find I have GNE myopathy also. I've made a mistake before. Yeah, if you go to your website later, you can see.
I mean that when they send patient to me, I will check EMG again, EMG again before I do the
I know.
Đó là lý do mà mấy bạn nhiều khi là gửi bệnh tới cho mình đó, thì mình cũng sẽ làm một cái điện cơ lại trước khi mà mình sinh thiết cơ, tránh cái trường hợp đáng tiếc này là đánh giá nó không cái gì lý do chủ quan và khách quan đánh giá bệnh cơ nó bị lệch, cái gì không đúng sai.
Yeah, so unfortunately this is inconclusive. You need more, well, at least ATPase, and maybe P62 would be helpful, but in this case you didn't perform immunohistochemistry against P62, because the one possibility, as Dr. Myopathy mentioned, like one possibility is like a myofibrillar myopathy or GNA myopathy. In those cases, we see rim vacuoles or protein aggregate, which can be detected by P62 immunohistochemistry, which is more sensitive than modified gamma retrichrome. So that is something you may want to do. But I don't see anything like that on at least H&E and modified gamma retrichrome. So for me, this is non-specific at all. Yeah.
Nếu mà bệnh GNE thì chúng ta sẽ tìm thấy thể vùi, đây là bệnh cơ trọng chi mà có cái hiện diện của thể vùi trên cơ thì nó trên background, thì thầy Nishino đã coi kỹ là không có cái đó. Thì nếu mà mình dựa với B62 thì đây là đối với thể vùi, những cái sợi cơ có thể vùi thì nó sẽ tăng mặt với lại B62. Nhưng mà đáng tiếc ca này thì không có là B62, tại vì mình chỉ định cho một cái bộ viêm thì ta sẽ dựa cho viêm, mà không phải viêm thì mình sẽ dựa cho bộ dystrophin, cho nên là cái nhóm này mình không có nghĩ là bệnh cơ do viêm, cho nên không có nhận định.
So for this type of complicated cases, I think you need full investigation, including whole exome sequencing, maybe even together with the blood from family members. I would do that, because this there remains a possibility of hereditary myopathic condition, right? It looks a bit selective. I'm not 100% sure, but you know, especially for this type of unsolved cases, I think we need full investigation. Yes.
Đối với những trường hợp khó này thì thầy sẽ làm xét nghiệm toàn bộ kiểu gen, ngay cả xét nghiệm kiểu gen cho gia đình luôn.
You want to open the thing? I want to show you something. So I think the other thing for patients where we can't do it, I often do also an echo for such patients. Echocardiogram.
Cardiogram.
Yeah, because these patients are generally quite well, right?
Right.
So it's quite a benign disorder, but if they have cardiomyopathy, it's a dangerous condition, right? So I screen the heart.
Yeah, of course.
Just get it out of the way, so that because this he's probably going to manage quite well. So if you go to nerve, if you go to nerve, go away to the.
And also I would do whole body CT, because it's interesting. I was not very sure. You know, he couldn't do this very well.
Yeah.
So maybe subscapularis muscle may be really affected. So we are still in a learning process. I'm not very sure. So if you see subscapularis muscle involvement in him, you can tell that probably this is very useful rather than this one, right? So I think they would be very helpful.
So motor, the pure motor ones are not here, right? This is sensory, huh? This is sensory, so motor. Huh? hereditary. See? So here we have this HMN. We have quite a few here, right?
Right.
Which are distal motor neuron disease. And then we have the distal SMA. So it's very confusing because the CMT people call it pure motor CMT. The motor neuron disease people call it distal SMA, right? But I think probably the same. They are the. So we have distal SMA. We have 1, 2, 3, 4, 5, and then we have hereditary motor neuropathies. So I find it difficult to sort out these things, to be honest.
Đối với SMA đó thì số người nói là cái CMT Cacometus đơn thuần vận động, còn những người bệnh thiếu motoneuron thì nói là cái SMA hoặc chi thì nó cũng rắc rối, cũng khó.
But do echo just to be sure, because he's going to do quite well, right? He's not going to be he's not disabled.
Yeah.
But if he has cardiomyopathy, it may be dangerous.
Okay.
So I will do echo for such patients.
Thầy
But
cũng gợi ý là
the other suggestion is to do the whole genome sequence, like he said.
Thì thầy gợi ý là cũng là làm biopsy để tìm xem bệnh nhân có bệnh tim kèm theo hay không. Tại vì bệnh cơ này thì ở bệnh nhân này không có tàn phế thì vẫn vận động được, vẫn sinh hoạt được, vẫn đi làm được. Tuy nhiên bệnh tim á, trong cái bối cảnh của bệnh cơ di truyền nó có thể đe dọa tính mạng của người bệnh, cho nên thầy khuyến cáo mình sẽ làm siêu tim.
Okay.
No
Finish
family
it.
history of dementia or bone disease? Not at all.
I didn't check that.
No, okay. Because the last one here, what they call IBM PFD, this one, not just, there are several genes, causative genes, like BCP or P62 or whatever, but they showed autosomal dominant disease with frontotemporal dementia and Paget's disease of the bone. So I think for example, pathological, bone fracture like spine fracture, can happen in elderly patients, right? So you may ignore it. So I think you need to carefully ask them. Yeah. So in that case, there may be that type of possibility. And another one is, I'm not sure if this is a myopathy or whatever. So certain gene mutation like DNA JB6, DNA JB4, they actually cause, very myopathy similar to rim vacuolar myopathy, but rim vacuoles may not be so obvious as compared with GNA myopathy. So in that type of myopathy, I think maybe like this, but I'm not very sure. Again, this is inconclusive, so I think you have to cast a wider net. Yes. And I would do whole exome sequencing. Yes.
Okay, I've got a few cases to show.
Thầy cũng đã có vài ca nhiễm trùng.
Let's just connect this for me.
Okay. Thank you. So what is the next menu program?
Just a few cases that I didn't show yesterday.
I see.
Okay.
Okay. Okay.
So we were discussing some of the cases yesterday. So the BVO sign, right? So this is another patient to illustrate the key features. Oops. Okay, you can see the asymmetric wasting of the asymmetric scapular winging. I think Dr. Nishino was mentioning how in FSHD the periscapular muscles are otherwise not wasted, right? You want to mention? So you can see the muscles, infraspinatus, supraspinatus, they are very fleshy. It's only the scapula that's winging with the curious scapula. But you notice here, all very nice and fleshy, right? And then the asymmetry. So this is classic FSHD, right? And again, you look at his face, lower face more than upper face.
Đây là cái scapular winging nhưng mà do nó yếu những cái cơ. What weakness? What muscle is the atrophy?
So no, Dr. Nishino was saying in FSHD, the suprascapular muscles, infrascapular muscles, supraspinatus, infraspinatus is not wasted.
Right.
You can see here,
Typically, right.
it's very fleshy.
Thì cái cơ trên gai và cơ dưới gai này sẽ không bị ảnh hưởng rất là mạnh, rất là nhìn nó không có bị đau.
Yeah, and then the lower face.
Và cái vùng mặt dưới nó không bị ảnh hưởng.
Upper face not too bad, lower face very severe.
Nhưng mà vùng cái mặt trên này là không bị ảnh hưởng.
And then of course the beaver sign, right? Then to show you that the beaver sign, this is another patient. You often put a stick like this so that you can see it better. Okay? And to prove to you that it's due to muscle here is normal, muscle here is abnormal.
Cái cách khác là chúng ta dùng một cái que để chúng ta chứng minh là cái rốn này nó có đi lên đi xuống, và cái cách thứ hai là chúng ta gõ vào cái cơ.
So you see what I'm doing here? You can see the muscle is normal but absent.
Cái phần bụng trên thì cái cơ nó vẫn còn nhảy lên khi mà chúng ta gõ nó, nhưng mà ở dưới thì nó biến mất rồi.
So then this patient is another Burmese patient, very thin, right? And his findings are less obvious, but his beaver sign is very obvious.
Cái bệnh nhân này là người Myanmar thì cái
Can you see that?
không rõ lắm, nhưng mà chúng ta khi mà gõ thì thấy nó
Is CK high in this
Absent.
patient? There are necrotic and regenerative fibers. How is the CK?
Okay, then this one, beaver sign, you see that?
vivo ra thì rõ.
Very obvious, huh?
Creatine
Okay.
kinase.
Then this is a scan, CT scan, to
Or
show these muscles
800.
normal, but here wasted.
Ở cái bệnh chụp CT bụng thì chúng thấy là cái cơ nó còn lúc trên nó thì nó bình thường, phía dưới nó bị mất.
Okay, so this again to show you why the scapula is curious. The upper trapezius muscle is normal, lower trapezius muscle is. You see that?
Lý do tại sao mà có scapular winging thì cái phần trên của cơ hang thì bình thường, nhưng mà cái phần dưới thì nó mất phản ứng.
The lower trapezius affected, and then similarly,
Cái phần thấp của cơ
you can see his face. Lower face affected more than upper face.
cơ mặt dưới cũng bị ảnh hưởng nhiều hơn trên.
Okay, then this patient I showed you all yesterday, I thought was FSHD because of this, right? Because of this.
Bệnh nhân hôm qua là thầy cũng đã đi bệnh viện đi quan sát nó khá rõ.
He's got a beaver sign. Okay, and if you were to tap on his muscles, okay, here again upper trapezius I thought was better than lower trapezius.
Chúng ta thấy rồi nữa là cái phần trên của cơ hang.
Okay, but I think Dr. Nishino, you want to comment on this muscle here?
Yeah, so you can see the spine of the scapula very well. It means that supraspinatus and infraspinatus are very much atrophic, which actually almost excludes the possibility of FSHD.
So it's not FSHD.
Right, I believe so. And also you can see paraspinal muscles are atrophic. You can see the spine well, prominent. It means that paraspinal muscles are also atrophic, right? I think in this case, I would actually suspect the possibility of late onset Pompe disease. Of course, it's rare, but because it's a treatable condition, I think you should prioritize that.
We have to find the patient.
Yes, and also when he was lying down, it looks like he has some respiratory, I guess, problem.
Thì Nishino nói rằng những cái bệnh nhân là các cái chi thì nó không có teo trên gai dưới gai, nhưng mà bệnh nhân này teo rất là nặng, cái cơ
But his face is also affected.
I see.
So can he have face involvement in?
Usually no.
Not in.
No, not usually.
You saw
no
his
in-
face. Huh? I'll
yeah,
show you the face.
right.
You just watch him when he closes his
But
eyes.
of course, there are always exceptional cases. So again, we are always learning process.
Yeah.
In the learning process. So
But you see.
I want to know the
see.
answer.
Let's play this video. Watch his face. Huh?
yeah.
See that?
For me, it looks like his chest expansion is
Very poor,
much
so, huh?
limited, right? So I think the diaphragm is affected.
So this patient we didn't biopsy also, right? This was about 5-6 years ago.
I see.
and
This is from Vietnam.
Yeah, Vietnam.
I see.
I think Hanoi. Huh?
I see.
Hanoi. Yeah.
Yeah. Because in China, there are so many Pompe disease patients. It's 10 times higher
Is it?
because of the frequency. Now, because of the mutation frequency, 10 times higher than Japan. So Hanoi is close to China, right? So I think this patient may have Pompe disease.
do là nó có teo cơ trên gai dưới gai và yếu teo rõ cái cơ cẳng sống, cho nên Nishino nói còn một khả năng nữa là Myopathy thì cái bệnh này là bệnh kiểu đường, cho nên là đừng có bỏ sót. Nishino nói mà đi tìm bệnh nhân hệ sinh thiết, nếu bạn có thấy đâu chỉ về bệnh nhân.
Very
If
nice.
you find a patient, send him to me to
Yeah. After I'll
Well,
call.
you can do the dry spot.
Oh, yeah, that's
test.
true.
Yeah.
Right.
Okay,
can
so then
see-
this one I showed you all yesterday.
I'm not 100% sure whether this is
This I
myopathic
showed.
or
Okay,
neuropathic because
percussion
there are
myotonia can be
hypertrophic fibers
picked up
and,
this way.
Hypertrophy fibers, yes. Can I show the?
I showed you all these patients. Okay, this one is a patient I saw Ho Chi Minh City, right?
Yeah, selective. You are right. But
CPO
at the same
sort of
time, you can see
picture in the
streak
family.
lines, right?
Okay, what about this palate?
Yeah, but yeah, you are right. This can be.
Very high, right? And you look at the face, long, thin face. So it's either congenital myasthenia or congenital myopathy. This man also same thing, congenital weakness. Okay, yesterday I was trying to show you this. Okay, this is the picture. Dr. Nishino, you want to comment on this? You think this is not so accurate, right?
Well, I think this is really, it's almost like philosophy. So
So basically, I was trying to make a point that there is isolated myopathies, connective tissue diseases,
right.
and malignancy.
Yeah.
But then, but you were saying NXP2 is not really pathologically dermatomyositis, right?
No, it is.
It is. Which one is the?
It is.
Which is the one?
NXP2, T-fan gamma, MI2, MDA5, and SAE. Those are dermatomyositis. So
Good.
for
Which one
me-
were you saying yesterday? That was perifascicular
No,
necrosis.
yeah, well, that is Joan.
Joan. Oh.
Yeah. So for me, this is the dermatomyositis. This is the dermatomyositis. But clinically, like an ARS, Joan, they show, many cases show, skin rash. So clinically, dermatologists and rheumatologists, they call this also dermatomyositis. This is the clinical condition. Yes. And you have to be careful. So the definition of polymyositis, this is clinical. Okay. So many of SRP, HMG cell necrotizing myopathies, polymyositis. But you have to be careful. If you really carefully examine patients, some of those patients like 10% of patients also show skin rashes, even in necrotizing myopathy. Actually, some of those cases are clinically diagnosed as dermatomyositis. Yes. So, well, I'm not really convinced, sorry,
Sure.
about this one. Yes.
No, yeah, I agree. I just wanted to be sure. So this is a patient with, what do you think of this?
Right.
Yeah.
Thầy Lưu Mang nghĩ là cái nhóm bệnh cơ mà SRP, HCM-city là bệnh cơ đơn thuần không có ảnh hưởng cơ, còn cái phần còn lại là những bệnh cơ mà có tổn thương cơ quan khác. Thì cái giảng đồ này thì thầy Nishino cũng không có phản đối và cũng không có hoàn toàn đồng ý, bởi vì cái chuyện mà BM bệnh đa cơ nó là một cái đánh giá về mặt lâm sàng và bệnh nhân thận trọng, tại vì SRP đôi khi là bệnh nhân cũng có sang thương da. And one thing, Professor, I have several cases anti-SRP positive with ILD.
Right. Yeah. Sometimes they show.
Maybe 2 or 3 cases.
Right.
So this is not very accurate, right? This diagram is not very accurate.
So this is really conceptual.
Yes.
Yes. Keep modifying. So
Sure.
this is not the conclusive at all.
Okay. So what do you think of this skin?
Các bạn nghĩ cái da này thì như thế nào?
So it's a young patient. She's an office worker, but she looks like a farmer or a mechanic. There's a lot of this extra skin, thickening, like as if she's a manual worker, but she's actually an office worker.
Cái người bệnh nhân này thì không có làm việc nặng, nhưng mà bàn tay của họ thì thấy cái da nó dày, nó bong tróc ra như là một cái người nông dân mà làm việc rất là nặng.
Dr. Nishino, can I show you this one also? This one is a very extreme version of mechanic's hand, but he does have some features of dermatomyositis also. He's got some Groten's plaques here, but you see this?
Yeah, but if you see mechanic's hand, it should be antisynthesis syndrome.
Antisynthesis, yeah, I agree. But it's just that there was some overlap with Groten's plaques, right?
Right.
But if you see this hand? There's so much of thickening
Right.
that his hands can't even straighten. So this extreme version of mechanic's hand.
Đây là một cái bàn tay thở máy rất là điển hình. Thì khi thầy Nishino nói là nếu mà thấy cái bàn tay này thì nên nghĩ đến học cái anti-city.
See that?
Ngoài ra thì cái phần da quanh móng nó có bị tổn thương.
His finger movements are also restricted because there's so much of soft tissue thickening.
Cái vận động thì nó bị giới hạn bởi vì cái mô liên kết nó quá dày.
Because the concept of myositis is really, different from rheumatologists, dermatologists, and our, condition, and really confusing, and also really changing. So if you give me something like 20 minutes, I will show you the presentation, like inflammatory myopathy. Maybe I will have similar talk in Da Nam, but I think this is probably appropriate for this.
You can do that now very quickly.
Sure,
I'll just show you very quickly.
But after going to the toilet.
Okay, I'll
Give
just
me
show
3 minutes.
Okay, this is a patient I saw also with inflammatory myositis, but he had interstitial lung disease, and we thought the skin was very thin and tightened in the skin. So we think she has got scleroderma-like illness with myositis. Rheumatologist.
Đây là một bệnh nhân mà thấy là da nó dày lên.
Here.
Hồi đầu tôi nghĩ là cái sơ cứng bị.
Very tight skin, small mouth. So she probably is a mixed connective tissue disease.
You know, Professor, I have a case that with skin lesion, I do muscle biopsy, and with very remarkable necroplasm, I diagnosed IMNM with seronegative. But 2 years later, he has scleroderma.
Wow. Nice case, huh? Seronegative, huh? That's very good. Huh? So this one I've shown you. This is another patient with Kennedy's. See the chin fasciculation? So this chin fasciculation is very specific. So you ask them to do this, then you relax, then you. So it's a very unusual form of fasciculation. So that's why they call it complex action-induced fasciculation. You know, you have to do this, and you let go.
Fasciculation của bệnh neuron vận động khác á, thì nó sẽ xuất hiện không có liên quan tới vận động, còn với bệnh nhân Kennedy thì nó là fasciculation sẽ bị tăng xuất hiện khi mà vận động, do đó bệnh nhân theo khi chuông cái môi ra, cố gắng gồng chuông cái môi ra, khi mà thả lỏng thì nó xuất hiện rất là nhiều fasciculation.
See, when I do that, then it becomes very obvious. So when you do EMG also, we do that. We put the needle in, then you look at the tongue. And then this is what we do. We put the needle in, and then we ask them to do that. So there are some fasciculations on the face.
But movement disorder, doctor is saying it might be fasciculation.
Yeah. No, but if it's diffuse like that, I will call it fasciculations. So this one I showed you yesterday already. Then this is the mask patient I showed you yesterday. This is also another mask. Okay, so this, I want to just quickly show you another sign that's useful in myasthenia, the Kogan's eye twitch, right? So you ask them to look down, then come up, then the eyelids move a few times. So you watch the right side.
Đây là dấu Kogan.
Saw that?
Bệnh nhân mà nhìn xuống sau đó
So ask them to look down,
nhìn xuống không phải nhìn.
look down, look down, look down, then come up, then it just twitches. So it doesn't just come and stay, it goes up and twitches. So it's called Kogan's eye twitch. Okay, so useful sign. Saw that?
Khi mà mới nhìn lên thì nó sẽ đi qua cái lòng tử một chút rồi nó rớt xuống.
And then sometimes it twitches like that continuously.
Khi mà nhìn sang bên thì cũng có cái hiện tượng.
So we call it the lid hopping sign. This one is not important. This one I showed you already. Okay, this one. This interesting patient. Dr. Nishino, I must tell you. Okay, so this man, don't look at this first, okay? So he came to see me for bilateral ptosis and ophthalmoparesis. So I thought it was myasthenia, correct? But the test was negative and he didn't respond. So then I thought it was CPAO. I did a muscle biopsy, not suggestive of CPAO. Biopsy one of the muscles, proximal muscles.
Okay.
Not, so I just left him for many years. Then he went to see the eye doctors because his eyelids were getting more and more toast. Then the eye doctors did an operation for the eye, and they sent the muscle to the pathologist. And guess what? Actually, the muscle biopsy actually shows amyloid. I missed it. But the lid shows amyloid. Can you see this amyloid? So this is an unusual form of amyloid that presents with this bilateral ptosis, facial weakness over many years. And after a while, they develop this face. See that face there? That we call it cutis laxa. Cutis laxa. L-A-X-A. Yeah. So this is, so just to illustrate to you that initially I thought it was neuromuscular junction, then I changed to myopathy. In the end, it's a neuropathy. Neuropathic cause for bilateral ptosis and ophthalmoparesis and facial weakness.
Đây là cái bệnh nhân đến khám, cái hình đầu tiên là bệnh nhân lần đầu tiên khám thì với triệu chứng là sụp mi, sau đó là xuất hiện liệt quận nhãn. Hồi đầu thầy nghĩ là CPO là liệt quận nhãn ngoài tiến triển, sau đó sinh thiết một cái cơ gọi gốc chi, kết quả bình thường. Sau đó thì bệnh nhân đi đâu đó thời gian sau để khám mắt, thì khám mắt thì bác sĩ mắt là sinh thiết cái cơ vận nhãn thì phát hiện là amyloid, có bộc lộ amyloid. Thì theo thời gian thì cái mặt bệnh nhân sẽ xuống. Hồi đầu là nghĩ là triệu chứng này là của cái mặt thần kinh cơ, sau đó là nghĩ tới bệnh của cơ, cuối cùng đó là cái bệnh của dây thần kinh vùng mặt làm cho cái cơ nó bị teo và yếu đi.
This is the one, cutis laxa. So you see when he's a young man, and then now at this age, his whole face becomes You know, it's a lot of extra skin. So that appearance is very characteristic. Cutis laxa. So it's actually a form of neuropathy. This one I think I've shown you all before, right? Fabry's disease, the small fiber neuropathy. Wait, let me see whether there's one more case I wanted to show you.
I think this is this one.
No more. That's it. So you want to show us a bit of,
Yeah, right.
you want to just show a little bit of dermatomyositis.
Khoảng 15 phút thì Nishino nói về viêm da cơ.
Dạ, Nishino nói khoảng 15 phút về viêm da cơ nha. Thật ra em nghĩ rất là khó để đưa được hai thầy tới, nên là hai thầy rất là nhiệt tình để nói chúng ta nên là mình tranh.
So previously, myositis was divided into just two, dermatomyositis, polymyositis. Then IBM came. So maybe there are three myositis, dermatomyositis, polymyositis, IBM. And this classification is still used by rheumatologists and dermatologists. But actually, it is changing, really changing. And now widely, at least in muscle pathology field, dermatomyositis as an independent subtype, anti-synthesis syndrome, it's like JO1 positive or anti-ARS positive cases, immune necrotizing myopathy like SRP, HMGCR, and inclusion body myositis. The color is dark because I used this slide for the meeting at the pediatric neurology because IBM they don't have any case with IBM.
Thì cái viêm cơ này á, thì cái bệnh định nghĩa ban đầu là có viêm da cơ, viêm đa cơ, rồi sau đó thêm được một cái viêm cơ thể bùi nữa. Thì theo thời gian thì cái phân loại này nó đã thay đổi rồi, nhưng mà cái phân loại này vẫn được tiếp tục sử dụng bởi các bác sĩ hấp khớp.
And there are other disorders, but they are well characterized, less well characterized, like overlap syndrome, anti-mitochondrial M2 myositis, MG-related myositis, and maybe others as well. Okay, so I will talk about dermatomyositis. So you know that dermatomyositis is characterized by heliotrope rash, Gautron sign, or other dermatomyositis typical sign. And I already talked about this one. The perivascular atrophy is typically seen. Another important feature, classically known, is a capillary MAC. MAC is a membrane attack complex, or C5b9 complement deposition onto the capillary. So many people used to believe that capillary is affected. So it means that many people believe that somehow dermatomyositis is a vessel disease, like vasculitis. That's what all people believed.
Đây là VFA thì đã nói rồi, với cái thuốc nhuộm và phức hợp MAC đó, phức hợp vàng đó, thì chúng ta thấy là bắt thuốc những cái mao mạch, cái viêm mao mạch ở trên sinh thiết cơ thì gợi ý cái nguyên nhân mạch máu của viêm da cơ.
But around 15 years ago, the guy in Boston called Green-Steinberg, he did a really interesting study. At that time, he used cDNA microarray to search for which gene is upregulated, highly expressed in dermatomyositis muscle. And he compared with muscle from other myositis.
Một cái nghiên cứu của một cái bác sĩ đó là họ tìm xem cái gen nào nó biểu hiện quá mức so với cái phần còn lại của viêm cơ trong cái nhóm viêm da cơ.
And he found that what he found was all the genes known to be upregulated by when you have type 1 interferon are all upregulated, including ISG15 or MXA. So this is from muscle from dermatomyositis patients. They are blue one indicates muscle from other myositis. Okay, so clearly in dermatomyositis, ISG15 is upregulated, MXA is also upregulated.
Thì họ phát hiện ra cái MSA và ISG15 thì nó upregulate trong cái nhóm viêm da cơ.
So based on this one, now increasing number of people think that dermatomyositis may be type 1 interferon, caused by type 1 interferon.
Do đó là họ nghĩ là viêm da cơ là liên quan đến type 1 interferon type 1.
And this MXA expression can be evaluated by immunohistochemistry. So if we do immunohistochemistry, in dermatomyositis you see many fibers, muscle fibers express MXA, but in normal muscle, never. You don't see it.
MSA cũng là một cách để chứng minh về mặt hiệu hóa mô miễn dịch. Thì chúng thấy viêm da cơ thì nó tăng bắt thuốc mà cái mẫu bình thường thì nó không có hiện tượng này.
So we have ever evaluated the diagnostic utility of this myofiber MXA expression. So perivascular atrophy, this is the best, classically known one. This is specificity is 98%. So this is practically speaking, if you see it, you already have diagnosis. 98% is almost like 100%. But the problem is sensitivity. Sensitivity is less than half. So it means that if you have it, you can make a diagnosis. But the problem is you may not have it.
Cái PSA thì nó rất là đặc hiệu, mình thấy nó là 98% chẩn đoán là được rồi, nhưng mà vấn đề là dưới một nửa số bệnh nhân thấy cái hiện tượng này.
So this is also the case for capillary MAC deposition. Well, specificity is 93%, a little bit lower, but still, if you have it, you can make a diagnosis. But the problem is sensitivity is even lower.
Cái độ nhạy của MAC, bắt thuốc mạch máu của MAC cũng rất là thấp, mặc dù độ đặc hiệu tương đối là cao.
Yeah, but myofiber MXA is, you see, specificity is 98%. So if you see it, you can make a diagnosis. But sensitivity is much higher than perivascular atrophy. So this is very useful for the diagnosis. So this is the best method to make a diagnosis of muscle pathology.
MSA thì nó gia tăng rất là đáng kể cái độ nhạy. Đây là cái phương pháp tốt nhất để chẩn đoán viêm da cơ.
Yeah, this is most likely because perivascular atrophy is here, but MXA expression is probably wider. That's why if you do muscle biopsy, even if you don't have perivascular atrophy, you sometimes see MXA expression. This is why you can have higher sensitivity.
Tại vì PSA thì chúng ta thấy là cái khoảng nhỏ của cơ thôi, còn trong khi cái nhựa MSA nó bắt hút một cái quang trường lớn hơn, chúng ta sẽ không xảy ra cái chuyện là bỏ sót cái PSA.
This is 1 year and 9 months old girl. The clinician suspected to have dermatomyositis. But on muscle pathology, no abnormality at all. So if this was like 20 years ago, we would say, oh, muscle was normal, sorry, no diagnosis. But if you do immunohistochemistry against MXA, you see muscle fibers express MXA. So we can now confidently say that, yes, this is dermatomyositis. So MXA immunohistochemistry is very powerful and reliable diagnostic method. Now, all the laboratories actually in the world actually started doing this staining because this is so useful. So now dermatomyositis, increasing number of experts believe that dermatomyositis is type 1 interferonopathy. This is, of course, this concept is important for the diagnosis, but it's also important for the treatment. Because if this is if type 1 interferon is the cause of the disease, and if all the symptoms like muscle weakness and the skin rash, everything is caused by type 1 interferon. So if you can block this type 1 interferon pathway, you should be able to treat the patient.
Nếu mà nó không phải là chỉ quan trọng cho cái chuyện chẩn đoán là interferon type 1 hay không, mà nó còn quan trọng cho cái chuyện điều trị. Tại vì nếu mà chúng ta nghĩ tất cả các triệu chứng này liên quan đến interferon type 1 thì chúng ta chỉ cần block nó lại là chữa được bệnh.
So you can actually block this type 1 interferon pathway. When type 1 interferon exerts its function against the target cells, it first interacts with the interferon receptor. Then interferon receptor activates Janus kinase or JAK. And this JAK phosphorylates transcriptional factor STAT1 and STAT2. And they are once phosphorylated, they make dimer. This is the active form of transcriptional factor, and then they go into the nucleus, and many genes will be expressed, including MXA and ISG15.
Interferon thì nó không giúp cái bệnh mà ban đầu nó gắn vào cái receptor, sau cái receptor check đó là mới thúc đẩy một cái loại cái quá trình phản ứng, từ đó mà nó express cái gen ở trong nhân, từ đó nó gây ra cái MXA hay là những cái hormone dịch khác.
So if you use JAK inhibitor, there are several JAK inhibitors, you can block this pathway, right? So yeah.
Nếu mà chúng ta chặn đứng cái check inhibitor thì chúng ta sẽ block được cái quá trình cái bệnh này.
So this is just the result of PubMed search. I did PubMed search. So there are 3 representative JAK inhibitors: ruxolitinib, tofacitinib, and baricitinib. I just did PubMed search dermatomyositis, ruxolitinib, or dermatitis, tofacitinib, dermatomyositis, baricitinib. So the number of papers are really increasing rapidly.
Và những cái thuốc mà ức chế chất này thì càng được về sau thì những cái nghiên cứu nó càng rất là nhiều.
And all of these papers, report the efficacy of JAK inhibitors in refractory dermatomyositis.
Refractory.
Dermatomyositis, refractory to steroid or whatever usual therapies.
Tất cả những nghiên cứu này thì chứng minh được hiệu quả trong những cái viêm da cơ không kháng trị.
So this indicates that type 1 interferon is really important for the mechanism of dermatomyositis, and this concept is very useful for the development of therapy as well, right?
Do đó chứng minh là cái vai trò của type 1 interferon thì nó quan trọng trong cái việc nghiên cứu về điều trị ung thư.
This is just demographics. Actually, all cases, we have more than 400 cases pathologically diagnosed, confirmed, to have dermatomyositis by the expression of MXA. So you can see double peak, you can see big peak in pediatric range. So this is why when pediatricians talk about myositis, they always say JDM, juvenile dermatomyositis, because they have big peak here.
Đối với khoảng 400 ca mà được chẩn đoán viêm da cơ trong chúng tôi và cái phương pháp MSA thì cái bệnh nhân nhỏ tuổi dưới 15 tuổi thì cũng có, nhưng mà các bác sĩ rheumatologist thì gọi là JDM.
So, but there are 5 autoantibodies specifically associated with dermatomyositis: anti-Tifran gamma, NXP2, MI2, MDA5, and SAE. So virtually all of the MXA, the dermatomyositis pathologically confirmed by MXA expression are positive, one of those 5 antibodies.
Có 4 cái kháng thể đặc hiệu cho viêm cơ gây ra cái bệnh viêm da cơ.
And the most frequent one is Tifran gamma, but the second most common is NXP2. But this pattern is different. The distribution of each, the demographics of the patient is different depending on positive autoantibodies.
Bệnh nhân nhỏ tuổi thì cái phân bố nó lại khác đi. Tiếp một gamma ít hơn NXP2.
So this one is pediatric range. So T4 and gamma is the same actually. You have big peak and also adult peak as well. But when it comes to NXP2, you have very big peak among pediatric ages, right? But when it comes to MI2, yes, there are some patients, but very, very few. MDA5, not so different. SAE, no patient. So actually the antibodies, depending on positive antibodies, clinical characteristics are different.
Rõ ràng là cũng giống mình thấy là đối với những cái kháng thể khác đó thì nó các việc về tuổi thì không rõ ràng lắm, nhưng mà nhóm NXP2 thì cái độ tuổi trẻ thì nó sẽ nhiều hơn.
And if you divide into the juvenile and adults, of course, the positive own antibody, the ratio is different. NXP2 is the most frequent among pediatric patients, while adult patients, T4 and gamma is the most common.
Chúng tôi chia làm hai nhóm adult và nhóm juvenile, thì cái nhóm rõ ràng là cái phân bố của nhóm juvenile và nhóm adult thì nó có khác biệt nhau. Ở nhóm thanh thiếu niên thì nó là cái độ là NXP2, trong khi nhóm người lớn là T4 and gamma.
Again, all those cases were confirmed. The diagnosis was confirmed by MXA expression or muscle pathology.
Tất cả các ca này đều được confirm bởi cái lượng MSA.
Okay, so then it's now known the subtype of the dermatomyositis by positive autoantibodies. They show different clinical features.
Và những cái kháng thể này nó sẽ biểu hiện những cái
For example,
yeah.
for example, T4 and gamma positive cases, at least in adults, this is highly associated with malignancy.
T4 and gamma thì nó rất hay theo với ung thư.
MDA5, it is highly associated with CADM, clinically amyopathic dermatomyositis. It means that they show skin rash but almost no muscle weakness.
MDA5 thì nó hay cái bệnh cảnh viêm da cơ mà ít có tổn thương cơ. Trong bệnh nhân thì thường có những cái sang thương da rất là nặng nhưng mà cơ thì không yếu nhiều.
They often show what they call inverse Gottron. So they Gottrons like rash on the other side of the, on the palm side. This is palmar papule. So this is typically seen in MDA5.
Bệnh nhân những MDA5 thường là những cái sang thương da, gọi là những cái dấu gột tròn đảo ngược, thì những dấu gột tròn thường là nó xuất hiện ở mặt lưng bàn tay. Tuy nhiên nhóm này thì lại xuất hiện cái gột tròn ở lòng bàn tay.
Another important issue is rapidly progressive interstitial lung disease, which is actually lethal. Many patients die because of this one.
Cái tổn thương phổi tiến triển nhanh thì là nguy cơ tử vong rất là cao, hầu như là chết hết.
And MI2, more severe muscle weakness and high CK. In fact, if you look at muscle pathology, there are so many necrotic fibers.
MI2 thì lại gây ra bệnh cơ rất là nặng, khi mà chúng ta sinh thiết cơ thấy hoại tử rất là dữ dằn.
NXP2, as I discussed, there are so many pediatric patients, and in chronic stage, they often develop calcification. And the cine dermatitis, I discussed about this yesterday, but I will talk.
NXP2 thì thường là không gây sang thương da. Đối với những trường hợp lét da mãn tính thì nó sẽ canxi hóa sang thương.
SAE, they often show this type of diffuse erythema in the back.
SAE thì gây lan tỏa, đỏ da lan tỏa.
Yeah, but typically sparing scapular region. So some people call it like angel wing. It's like wing, right?
Cái phần xung quanh cái xương bả vai thì nó gọi là cánh thiên thần.
So the CADM, you have skin rash but no muscle weakness. This is CADM. It is associated with MDA5. The question is on the other side. Maybe you have muscle weakness but no skin rash. This is called dermatomyositis, cine dermatitis. Cine means without. But the problem is, because for rheumatologists and dermatologists, the definition of dermatomyositis is with those with skin rash. But for them, this type of concept is unacceptable, right? Because the definition is with dermatitis, with skin rash. But if you accept this one, you may have this one. So actually, because we can make a diagnosis purely based on muscle pathology without any skin, clinical information. And in fact, at one moment, at that time, we had 180 something because this is years ago. Interestingly, 8% of the cases don't have any skin rash. We actually send a questionnaire to the physician and ask them to follow up a certain period of time. They no skin rash. interestingly, most of the cases have NXP2 antibodies. So now we can say that yes, there is dermatomyositis sine dermatitis, and this condition is associated with NXP2, just as CADM is associated with MDA5 on the other side. So now we can say this.
Chúng ta có hai cái thái cực là một cái viêm da cơ thì có tổn thương cơ rất nặng và một cái viêm da cơ mà không có cái tổn thương cơ, không có tổn thương da. Do đó về mặt quan điểm lâm sàng của bác sĩ, một số bác sĩ thì thấy là phải có can thiệp da mới là viêm da cơ, nhưng mà chúng tôi chẩn đoán bằng bệnh học chẩn đoán viêm da cơ bằng bệnh học.
So there are differences in terms of clinical features. Because we do muscle pathology, for us, the question is whether there is any difference in terms of pathological features.
Vấn đề là về mặt quan điểm thì vấn đề là nó khác biệt gì về mặt bệnh học.
I don't go into the detail, but we did a lot of extensive study, and the answer is yes. And that there is, for example, perivascular atrophy is most often seen in MI2 positive cases, but NXP2 almost very rare, something like that. So I don't go into the detail. Yeah. And then T1 gamma, let's say perivascular atrophy, but they often show this type of punched out vacuoles, and capillary mark deposition is frequent. And MDA5, no perivascular atrophy, no capillary mark deposition is very rare. And XP2, we often see microinfarction, and capillary mark deposition is very prominent. Yes. Okay. So this is the summary. So this cartoon indicates the rough image of the distribution of the patients according to the age. So you have big cluster in pediatric patients and adult patients like this. But you have to be careful. Like 8% of patients don't have skin rash. So they may well be diagnosed as polymyositis by rheumatologists or dermatologists. So you have to be careful about it.
Cái hình này là những cái mà thầy nói nãy giờ đó, thì có 8% cái bệnh nhân viêm da cơ không có sang viêm da và được chẩn đoán bằng viêm da cơ bởi dermatologist và cái phân bố về tuổi khác nhau.
So anti-synthesis syndrome. Anti-synthesis syndrome is defined as myositis who has positive anti-ARS, anti-amino acid tRNA synthesis antibodies. There are 9 antibodies so far identified, so including JO1 and PL7, EJ, blah, blah, blah. And the most recently identified was anti-LY antibodies. Okay.
Chiến kháng Syntheta là một cái viêm cơ kèm theo cái kháng thể kháng Syntheta dương tính. Tới hiện tại thì đã có 9 cái kháng thể. Cái thường gặp nhất là JO1 và cái mới được chính là anti-L1.
And OJ is very tricky because each antibody basically recognize single amino acid tRNA synthesis. For example, JO1 recognize histidyl tRNA synthesis, okay? But OJ is different. There are several amino acid tRNA synthesis, and they make multi-synthesis complex. And OJ probably recognize this type of complex, like a 3D structure. It's okay, all right? All right, so this is the demographics. So then, rheumatologists and dermatologists often say that, okay, anti-synthesis syndrome is dermatomyositis, but it's not. The distribution is totally different. You almost have no patients in pediatric cases. So clearly, they are different diseases. And if you draw up maybe then I should show this one. So, of course, in our series, all cases are muscle weakness because all cases received muscle biopsy, right? So, among all these cases, interstitial lung disease, this is chronic one. Chronic one, 80%, and around 2/3 of the patients have some kind of skin rash, typically mechanic sense, just as you just learned from Dr. Myopathy. And mechanic sense. But can also show like V-neck or shoal sign, which is known to be seen in dermatomyositis. That's why they say that, okay, not typical, but dermatomyositis. Dermatologists often say that. And others like polyarthritis, fever, and Raynaud phenomenon, which are usually not seen in dermatomyositis. So this may be, helpful for the diagnosis. So like 2/3 of the patients show skin rash, right? So the cartoon will be like this. So almost no patient in pediatric range and mostly adults, and 2/3 of them are with skin rash and 1/3 without. So clearly, for rheumatologists, 2/3 of them will be dermatomyositis and 1/3 will be polymyositis, right? According to their definition. Okay. Then this is according to our in our cohort, JO1 is the most frequent, but OJ is the second most common. And again, OJ is very tricky. If you submit your sample to Euroline or whatever, OJ will never be positive, practically speaking, because again, OJ recognized very complicated structure, not the amino acid sequence, but line blot. They use just simple amino acid sequence as as the like antigen. But of course, it does not. Even if you have OJ antibodies, this one does not recognize simple amino acid sequence. So all the OJ positive patients will be false negative by Euroline. So you have to be very careful about it. Euroline or ELISA. Yes, always false negative. So you have to be very careful about it. Whatever you do, no way to detect it unless you use the original RNA immunopresentation. You cannot detect it. Yes, so this is very complex. So all the commercially available testing will give you false negative results for OJ. Don't trust them. It cannot be detected, technically, impossible. Okay, so let's discuss muscle pathology. The most important feature is perivascular necrosis. For some reason, nobody knows why, but necrotic fibers are clustered at the periphery of the fascicles. And if you have necrosis, of course, you also have regenerative fibers. So that's why necrotic and regenerative fibers tend to be distributed at the periphery. By the way, this is JO1 positive cases, okay? And another important feature is perimysium. Perimysial connective tissue is often fragmented like this, and sometimes alkaline phosphatase is positive. Alkaline phosphatase is normally present in the bone, but not in the muscle. But for some reason, in some myositis, you see alkaline phosphatase expression in perimysium. This is often seen in antisynthesis syndrome. Okay, so then if you do immunohistochemistry, HLA-DR or MHC class II is usually almost always negative except for IBM and antisynthesis syndrome. And in antisynthesis syndrome, 2/3 of the cases, like 60 or 65% of cases, show perivascular fibers, positive in perivascular fibers. Yeah, well, I don't go into the detail, but we recently studied this one. And then the question for us, again, the same. So depending on positive autoantibodies, maybe muscle pathology features are different or not. Then the answer is yes, and there was some tendency. I don't want to.
Can you show the earlier slide again? Sorry. The earlier slide.
This one?
The one before. Thank you. Thanks.
Yeah, so in IBM, practically 100% of patients show HLA-DR expression. In IMNM, very rare. Dermatomyositis is also very rare, maybe 15%. This is less than 10%, but IBM 100%. And antisynthesis syndrome, like 2/3 or even 70%. And the pattern is very different. In IBM, usually diffuse like this, but in antisynthesis, usually perivascular. Yes.
So in the earlier slide, you showed that the HLA-DL, the type 1 is diffusely present.
You mean MHC class 1?
Yes.
MHC class 1 is positive, whatever, regardless of
Sure.
type of the myositis, and it can be even positive in some type of muscular dystrophy, and even if you have a cold, probably it can be positive. So that is too sensitive, and it cannot be so helpful to differentiate subtype of myositis. Okay, so then again the same picture. You know, for rheumatologists and dermatologists, antisynthesis syndrome, ASS, is dermatomyositis, right? Because they have skin rash. So when I show this picture, one rheumatologist told me, look at this. There are atrophic fibers at the periphery, right? So this is perivascular atrophy. See, this is dermatomyositis. That's what he mentioned. But of course, they are regenerating fibers, right? Regenerating fibers is like a kid. They are in the process of growing up. So of course, the size is smaller. Yeah, but for him, yes, this must be perivascular atrophy. Yeah, dermatomyositis. Then how can we say no? This is different. If you remember, MXA. This is the same case, JO1 positive case. See, no fiber express MXA. Negative, okay? So it means dermatomyositis and antisynthesis syndrome are completely different disorders. Even though they look similar, they may look similar, you know, clinically or even pathologically, they may look similar, but different diseases. This is very important because the treatment, future treatment will be different. So you can just say, oh, dermatomyositis by the appearance, I think you will lose the chance to treat the patient because the mechanism is completely different. I will just briefly go through immune-mediated necrotizing myopathy. We had a case, right, today. So, of course, clinically, what they call clinical polymyositis very much, and CK is very much elevated. Usually no skin rash. Usually means you can rarely have it. So this is probably not typical dermatomyositis, and this also not typical dermatomyositis, but can show skin rash. And actually, if you read the papers submitted by the group of group of dermatologists, actually, among all the cases diagnosed as dermatomyositis, some patients have anti-SRP antibodies or anti-HMGC antibodies, according to them. So it means that dermatologists really make a diagnosis of dermatomyositis when they see skin rash, whatever the disease is. But of course, different diseases. And you know, SRP and HMGC are the two specific autoantibodies. So you see the distribution is like this. Of course, adult, but you have to be careful. There are pediatric patients as well. Not so many, but there are cases. So this is also important because many of pediatric cases are misdiagnosed as muscular dystrophy, and they were left without any treatment. Yeah, for example, case number one, the case number one onset was probably 10 months old. And he came to the clinic like 3 years something. And imagine that you have 3 years old boy, you know, having progressive muscle weakness, very high CK. Of course, you think about muscular dystrophy. But actually, in fact, he had myositis. So you shouldn't actually miss the diagnosis and delay the diagnosis. And almost all cases already have fibrosis, and the efficacy is already limited. So if you draw the same type of cartoon, rare, but you still have those with skin rash, right? So you have to be careful about it. Okay, so again, dermatomyositis and antisynthesis syndrome, they have different mechanisms. They are different diseases, right? So future direction is, I think there must be subtype specific mechanisms. So understanding the mechanism is very important. So based on the specific mechanism, probably the specific therapy will be developed, not just steroid. And so I, draw up everything. So again, those without skin rash may be clinically diagnosed just as polymyositis, and those with skin rash may be diagnosed with dermatomyositis, but they have totally different disorders. So this is a very important point. Okay, that's it.